Welcome back. Neck pain can be very scary. It can be debilitatingly painful to the point where you're not getting out of bed and it feels like it's not going away. Sometimes it's accompanied with numbness and tingling that travel from the neck all the way down to the fingertips. If that sounds like you might have cervical radiculopathy. And in today's video, I'm going to show you what that is, how that usually happens, how we evaluate it, and how we usually approach treating it. So let's get down to it. Cervical radiculopathy, cervical meaning neck, and radiculopathy meaning impaired function of nerves, is when a spinal nerve coming off the neck or a group of spinal nerves are compressed or pinched or inflamed, resulting in pain, numbness and tingling, or impaired reflexes from the neck all the way down to the fingertips. Depending on what nerve or nerves are affected, you'll see a different pattern of symptoms. Fortunately, about 90% of individuals who have cervical radiculopathy will not require surgical procedures. And of those individuals, about 80% of them will get better or be symptom-free with conservative care, whether that's through means of physical therapy or through medications. There are two common ways for people to get cervical radiculopathy, and the first being bone spurs and the second being disc herniations in the neck. Bone spurs, also known as osteophytes, are bony protrusions that form on bony surfaces of joints due to osteoarthritis. Osteoarthritis occurs when joint surfaces undergo enough wear and tear that it ends up forming calcium deposits, and if bad enough, the calcium deposits start turning into bony projections, known as the bone spurs. We normally expect bone spurs to occur in individuals of advanced age due to the amount of repetition and wear and tear required for those bone spurs to form. The one common spot for bone spurs to build up is in the facet joints in the neck of the spine. If we take a look at the spine model, this side being the back and this being the front, we'll see a pair of facet joints toward the back. As you can see, the facet joints dictate how much and what kind of movement occur in the spine. Over time, the cartilage or protective layer on the ends of each bone will wear down, and in this case, it occurs for everyone. Once this happens, this is when we would expect osteoarthritis to occur and then build up of bone spurs. Over time, the cartilage or protective layer on the ends of each bone will wear down. Once this happens, this is when we would expect osteoarthritis to occur. These said bone spurs can protrude anteriorly, meaning towards the front, and make the foramen, which are the holes right here, smaller. The spinal nerves, as seen here as the yellow cords, pass through the foramen, and if narrow enough, it will then compress the nerves and can cause pain or other symptoms. Another common spot for bone spurs is at the uncovertebral joint, or also known as the joint of von Luschka, which we can see here on the front end of the spine model. Over time, discs begin to lose their height, which is why we get shorter as we get older. When this happens, it brings the joint closer, leading to more arthritis and narrowing of the foramen in which the nerves come out of. The second cause of cervical radiculopathy is disc herniations. As a review, a disc is a cushion between the bones of our spine. A disc herniation is when outer layers of the disc, called the annulus fibrosus, ruptures and leaks out a jelly-like substance called the nucleus pulposus. This leakage can apply pressure onto exiting spinal nerves coming from the spinal cord, causing symptoms. A less serious form of this is a disc bulge, where there is no tear in the annulus nor leakage of the nucleus pulposus or jelly. Disc herniations are mostly the result of normal, gradual, aging-related wear and tear, and this is called disc degeneration. As people age, the discs become less flexible and are more likely to rupture or tear even with the slightest twist or strain of their neck. The other way of getting a ruptured disc is through injury, whether that's through falling, a collision, or heavy lifting. But it's important to note that most people can't pinpoint a moment of injury if they do have a ruptured disc. Having said that, just because you have a disc herniation does not mean you will require surgery. Oftentimes, if given enough time, your body can naturally dispose of the disc herniation and repair itself. Most importantly, just because you have an imaging report, whether that's through an MRI or an X-ray saying that you have one of the conditions that we mentioned before, does not mean you'll directly have pain. Oftentimes, people can have compressed nerves, but may not experience any pain or symptoms. In fact, about 50% of people over the age of 40 years old have at least one spinal level with disc degeneration and are asymptomatic. This means that they have disc degeneration, but there's no pain, numbness, or tingling due to that disc degeneration. Even more surprisingly is that about 75% of people over the age of 70 years old are also asymptomatic with at least one level of spinal disc degeneration. This is why we often say treat the person and not what the imaging finds. This is not to say you shouldn't get surgery. I'm just saying I highly recommend that you should try all other options and conservative treatment before doing so. I think it's also important to hear that as scary and painful that cervical radiculopathy is, the damage isn't irreversible, and it's important to give your body enough time for your body to heal itself and get better. So when you see your primary care doctor or your physical therapist for the first time, you probably don't have your MRI report. And that's because most insurances don't let you get an MRI until you try physical therapy first. So first we would do an extensive subjective history on your pain's location, quality, and duration of time that you've had it. Pain, numbness, and tingling from the neck all the way down to the fingertips are characteristic of cervical radiculopathy. We'll also ask for any possible moments of injury, whether that's through a car accident, fall, or collision. These are just to name a few. So now you're probably wondering, Andrew, there are a lot of nerves that come out of the neck. How do you know which nerve is being compressed? Well, each spinal nerve has a profile of certain muscles that it supplies, areas of skin that it supplies, and certain reflexes that it contributes to. By testing each of these, we are better able to narrow down which nerves are being affected. We can also test for reflexes. Do you remember at the doctor's office when they would take a rubber hammer and then hit your knee with it and see if you would kick out? That's testing the integrity or the health of your nerves. So in this case, we would take a rubber hammer and hit your elbow. This is actually testing the C7 nerve. If your elbow straightens and kicks out like so, that's normal. But if it doesn't, or it just moves a little bit or slowly, we would think that you have cervical radiculopathy of the nerve C7, meaning that C7 is being compressed or pinched. So now we know that there's cervical radiculopathy. We know that there's a nerve being compressed, whether that's through a bone spur or disc herniation. But how do we treat it? So pain is coming from either of two things. One, the physical compression of the nerve, or two, the inflammation of the nerve, which is a response to the physical compression. So one mode of treatment is to remove whatever is physically placing pressure on the nerve, which is through various types of surgeries, but we will save that as a last resort. The second is to use whatever means to decrease the inflammation. That way, the nerve can learn how to live inside this cramped space that's being pinched in, or give the body enough time to deal with the disc herniation and repair itself. Typically, your primary care doctor will recommend that you have 3 months of conservative care. This can be through rounds of medications prescribed by your physician or through physical therapy. There are two common forms of physical therapy. First is passive physical therapy, in which little to no effort is required for the patient. Methods of treatment include cryotherapy, heating therapy, ultrasound, electrotherapy, traction, and much more. The main goal of this is to reduce inflammation and swelling to decrease the pain. This is what most patients start with in their individualized physical therapy program. Once inflammation decreases, a good physical therapy program will start incorporating active physical therapy into your treatment. Active physical therapy is when the patient themselves start to move to increase flexibility, strength, and decrease pain. By doing so, the muscles become more resilient, less painful, and better able to maintain optimal postures to reduce loads onto the cervical neck. The specific methods and treatment for physical therapy vary from clinic to clinic, which is why it's super important to choose the right one to go to. For most people, with a properly followed treatment program, they will find improvements within the 3 months. If not, your physician may recommend epidural steroidal injections. This is where they take an anesthetic, which is a numbing medication, and a steroid medication, which decreases the inflammation. They inject it into the space surrounding the irritated nerve within the spine in hopes of shrinking it to the point where the pain and symptoms go away. Epidural steroidal injections are a great way in buying the body enough time for the spine to heal itself. It's important to note that there's a limit of how many shots you can receive within a year, and that it's usually just a temporary solution as it only masks the pain. Usually shots are spaced out about 6 weeks, but it's up to your physician to decide how many shots you can receive altogether. If you find no improvements after your complete round of shots, your orthopedic surgeon may have a conversation with you about potential surgeries that could help with your condition. Surgeries such as laminectomies and fusions, posterior foraminotomies, anterior cervical discectomies and fusions, and artificial discectomies are all potential surgeries that your doctor can discuss with you in further detail. As an overview, we learned about what cervical radiculopathy is, how it happens, how it presents itself, how we evaluate it, and the potential approaches of treating it. Cervical radiculopathy is tough and painful to go through, and it can prevent you from living your normal life. Fortunately, it doesn't mean it's permanent, and you have a high likelihood that it's going to get better with conservative care. So make sure you talk to your doctor and see what solution is best for you. Well, that's it. I hope you enjoyed this video and learned a bit about cervical radiculopathy and neck pain. We really enjoy making these videos because we know how much it can empower a person to learn about their injury. If you like this video, make sure you give it a thumbs up, and if you'd like to see more videos like this in the future, make sure you hit the subscribe button and hit the notification button if you haven't already. Well, that's it. Thanks for watching and see you next time.